you know what I'm here to talk about, so I'll just get straight to it then, bearing in mind that I approach it very much with an interest in the institutional design of the system as a political scientist. I'm an institutionalist. Just if you would bear with me, have a little patience, because I understand some of you are coming from different disciplines. So the German long-term care system is widely regarded as a success story, both nationally and internationally. Its establishment in 1994, which is not all that long ago, represents a radical and path-breaking moment in welfare state history, in which a new branch of Social Security was created in the welfare state. And this branch has seen tremendous expansion in benefits, particularly for those affected by dementia, which represents a substantial portion of the elderly population and entails significant costs. This expansion, to appreciate how special it is, one ought to see it with a view to developments in other parts of the welfare state where restructuring and retrenchment has mainly been taking place, particularly in healthcare, since the early 1970s. To some extent, expansion in long-term care has even come at the expense of the other welfare state areas. And moreover, long-term care insurance in Germany has not been undermined by the recent economic turmoil that was seen in the financial markets or by Germany's interest in maintaining its status as a good place of foreign investment and production. In my presentation today, what I'd like to do is provide you with a brief history of long-term care services before 1994, because it helps to, in the language of institutionalism, explain why some path-dependent traits have remained and lingered on past 1994. I'd like to then introduce the basic features of a long-term care system, focusing particularly on administration, coverage, benefits, and financing. And with regard to financing, going into a little extra detail about the issue of expansion, because this is really quite remarkable. And then I'd like to finish up by discussing some of the strengths and weaknesses of the German system before suggesting some possible lessons for Canada as you guys undergo reform. If you have any questions along the way, I wouldn't be averse to you stopping me, although as you like. Beginning with services before 1994, the risk of requiring long-term care was borne first and foremost by the individual and his or her family, and as a last resort on the part of the municipalities in the form of a mean-tested social assistance scheme. And the policy rationale underlying this system, which was fragmented and not at all solidaristic, rested on two principles. The one that long-term care was a private risk, unrelated to your employability and the market, and therefore the responsibility of the family, particularly that of a woman in the family. And the other position was that, given the specific and varying needs of the elderly and disabled, that the local level would do a better job at designing services. As a result, in the instances where the family failed, the responsibility of care rested with the states or municipalities in terms of financing and in services charity organizations. Now, during the 1970s and 1980s, the status quo came under increasing pressure, and this was due to the deficits within the long-term care service system in access and quality, as well as high levels of poverty associated with the need for care. Some 80% of the population that was in nursing care was also dependent on social assistance. So these were very highly correlated, poverty and the need for care. These weaknesses of the system were met by substantial changes in the economic and demographic environment. And many of these we know about: the aging population. Birth rates also dropped tremendously since 1965 in Germany. There was a growing feminization of the workforce, rendering the female caregiver model obsolete, or increasingly obsolete. And there were, of course, the lingering effects of economic turmoil of the 1970s. This, alongside the growing need for care, really exacerbated the budgets of the local municipalities that were paying for social assistance. Despite these pressures, it did take another 20-somewhat years before the system would be created in 1994, and this has been attributed to a great number of veto players within the institution's design of the political system in Germany. There was a great deal of discord even within political parties and interest groups on how this reform should look and what the long-term consequences of a reform, would mean. But by 1994, political consensus finally gave way, and a new branch of Social Security was indeed created. So what did and does this system look like? Generally speaking, the German system was created with one very express prerequisite in mind, and that is cost control. How would that be achieved? By keeping the definition of need for long-term care extremely tight. And so entitlement was very, very narrowly defined. This prerequisite has often been at odds with the long-term care system's other policy objectives, which include providing social security against the risk of needing care, helping to reduce the physical, mental, and financial stresses related to the need for care, enabling persons to stay in their homes and age in place as long as possible. And this means emphasizing prevention and rehabilitation over care, emphasizing the outpatient sector over inpatient care, and short stay care over long-term inpatient care. Also very important is, as a policy objective, is improving Social Security for caregivers, and we'll talk about what that means exactly in a bit. And finally, expanding and consolidating the care infrastructure to encourage competition at the provider level. So bearing these policy objectives in mind, I'd like to now walk you through some of the basic features of the system itself, beginning with its administration. The German long-term care system comprises two tiers: the social insurance system and the private compulsory insurance system. For those, which is available for those people who are earning above an income threshold, which is currently at about 4,390 euro a month gross. Those people earning above this threshold may choose to opt out of the social insurance system and are then obliged to purchase long-term care insurance. The administration of the social insurance system is done by what is called the long-term care insurance funds, which are founded as branches of the social health insurance's sickness funds. But their accounting is quite separate and they are quite independent. It's important to note that unlike health insurance, though, there is no competition between the insurance funds, the long-term care insurance funds. So this is a really very strong distinguishing feature, and I'll get into it a bit more later. Competition can only happen at the provider level. Moving now to compulsory private long-term care insurance. This is actually administered by private health insurance companies, which is really quite remarkable because it represents the first instance in which the German welfare state gives a public task over to private companies. However, they are strongly regulated themselves by the state. They have to accept any entitled applicant, meaning anyone earning above the income threshold who chooses to opt out of social insurance. And this has to be done regardless of prior health status. Yes?
Private, but is it private for profit or private non-for-profit?
For profit. So, taken together, what we end up achieving, though, through this two-tier system is basically universal coverage, in which 90% of the population is currently covered under the social insurance scheme, and this includes programs for police and military that are slightly different and perhaps a tad bit more generous, and 10% who are currently under private compulsory long-term care insurance. There is something called supplementary private insurance that is optional, and they have tried, the government has created incentives, something called Pflegebar, but this has been, by and large, quite unsuccessful. Very little take-up of this supplementary insurance. If you have any questions, I'd be happy to talk about that later.
How many private insurance companies are there?
Oh, gosh. I'd be lying if I could quote a number, but I would,
Are we talking a handful or dozens?
dozens. We're talking dozens.
And how do, maybe you'll get to this, but how do you avoid cream skimming?
Well, this is a problem that is more easily tackled within the health insurance system because they have built-in ways to regulate against that. However, cream skimming, in terms of good risks only being taken, well, for one thing, prior health status cannot be taken into account. Anyone who earns above the income threshold and wishes to apply for the private insurance has to be accepted. So they can't just take good risks. Financially, they're taking better risks, clearly, because these are higher earners who are in the system to begin with. And then often with socioeconomic status, there are some typical better health associated with that, but they have to take all applicants irrespective of prior health status. Any other questions so far? Yes.
Do they regularly reevaluate your income in terms of whether you're still eligible for their insurance?
Oh, that's a good question. And it's funny because this is a question that never comes up within a German setting, probably because you don't have as much variability in income as you have in North America. I mean, particularly talking from the point of view of as an US American. There's a lot more stability in income maintenance, so this doesn't really happen. However, if you should become unemployed, for example, then you automatically are going into the social health insurance system, and then you thereby the long-term care insurance system, for example. The unemployment benefits will pay into your social insurance.
Your private social insurance, though?
Not your private, then you'd be slipping into social insurance system.
So any money you pay towards the private insurance company would be lost, would be what?
It wouldn't be lost. I believe they have some transfer schemes should you not make it back into the private system, and I think that they don't transfer you out immediately, but I would be lying if I knew exactly how long. But it's an excellent question. Reminds me of how important that becomes outside of the German context. Any other questions so far? Oh, so another hand, yes?
Yeah, just wanted to know about the age requirements or criteria. Does this kick in at 65? When do people start?
There are no age requirements. Unlike there are other systems like in Japan that also have social insurance, and there are age requirements. Here there are none. You have to pay into the system. Previously, it was, I think, up until 2005 or 2008, you had to pay into the system a minimum of 5 years, and now that's been reduced to 2 years to collect benefits. But if you should become dependent at 25 years old, then you are entitled to benefits.
So when do people normally start enrolling for insurance? There's no age at which everyone has to be enrolled? Or?
Under the age, I think, of 25, you're on your parents' insurance. And enrollment in the social insurance system is automatic. Okay. Just as it's an extension in a way of your membership already in a particular health insurance. For long-term care under the private system, then there is a proper enrollment process that takes place. And once you're no longer dependent of your parents, then you have to make the choice.
So suppose you turn 25, you're no longer dependent on your parents, and your income is high. Do you automatically get some sort of payroll deduction to pay your long-term care insurance unless you expressly opt out?
Exactly.
So it's like a payroll tax?
Yes, exactly right.
Lorraine, they're probably not familiar with what social health insurance actually is, everybody.
Okay, this is very, okay.
So,
well, I'm going to get to the financing of the system in just a bit. Thank you for pointing that out. I'm going to get into a bit more detail about how it's financed, so maybe that helps a bit. And if not, raise your hand again and let me know if you have any other questions.
Big bang, yeah.
It's just about the social health insurance fund and the relationship between the long-term care insurance. So if someone, is enrolled in the social long-term care, is it the same fund or is it a separate process? Do they get to choose?
You have choice because there's competition between the sickness funds within the health system. There is not competition in the social insurance long-term care funds. It's one pot of money that is distributed evenly, and this covers everything, including administrative costs within the social insurance scheme. So there you don't have choice. With the choice you have as a beneficiary is rather at the provider level, which service providers you want to work with.
So these funds are regional then, geographic as opposed to, so the statutory health insurance funds or sickness funds they used to be geographically organized and now there's a bit more sort of selection or opportunity for
That's right.
choice. So these funds there's just one fund per
Exactly.
area, region or state at the lender level or?
There are some that are at the lender level, and then there's one main pot of money from which the lender sort of take from at the central level.
Oh,
So it mirrors the federal system in a way.
okay.
Does that make sense?
Yes.
Okay. Any other questions so far? It's good that you pointed that out, Colleen, about the social insurance system being a bit of what that means exactly. I can go into that a bit more, but it becomes clearer now. Talking about what the benefits are, here we've seen a lot of change in benefits, and this has everything to do with the enormous expansion that we've seen, particularly since 2013. To walk through the basic features of benefits, benefits are capped and defined by law. Beneficiaries can choose between home care, day care, night care, and inpatient care. In the case of home care, recipients can choose between, and this I think is quite interesting perhaps for you today, for home care, beneficiaries can choose between in-kind services by professional providers and cash benefits, which are typically at a lower value, about half of the amount that you get for in-kind benefits. But these cash benefits are essentially given over to the beneficiary directly on his or her bank account, and the beneficiary can choose who he or she wants to give that money to for caregiving. So family member, friend. In the case of, thank you very much. Thank you. Excuse me a second. But in this way, informal care is formally recognized by the German long-term care system. And this very much has to do with the long history and reliance on the family that existed prior to 1994. Community care, in the meantime, is provided by both non-for-profit and for-profit organizations, and their costs are covered up to a certain cap by the insurance funds. Cash and in-kind benefits can also be combined. Depends on what the beneficiary chooses. So for both types of benefits for home care, payments are made in line with grades depending on the assessed level of care need of the beneficiary. Now, previously, these three levels of care existed, and now there's also something called a level 0, which I'll talk about in a bit more in a moment. Prior to 2002, this assessment was based in line with the measure of activities of daily living. But these have since been replaced by a measure of a scale that's much more comprehensive, roughly translated to a care dependency scale. Assessments are carried out by the insurance fund's medical review board for social insurance patients and by an independent private company, Medic-Proof, for the privately insured. So they'll come into the home, visit the patient, and see where the care needs lie. At each care level, benefits for people in institutional care are significantly higher than in-kind benefits taking place in the home, and in any case, much higher than cash benefits. Beneficiaries opting for in-kind benefits can choose amongst service providers with whom their insurance fund contracts directly. And they can also choose which services, in a catalog of options, they can choose which services they wish to receive by those service providers. In an effort to encourage competition, the service provider market has been open to private providers, and this I think was in 2004, 2005. And since then, there's been a huge increase in the number, excuse me, in the number of providers in the market. So this has done a good job to increase capacity in the infrastructure in any case. It bears noting, however, that despite its significantly lower value, cash benefits still remain the choice, the first choice of beneficiaries. And this reflects the patient's interest in having someone they know. Excuse me, I have terrible allergies and my throat is quite dry. Okay. This reflects very much the patient's interest or the dependent's interest in having someone they know take care of them. Although we have witnessed a small gradual increase in recent years in in-kind benefits by service providers, and this might reflect also demographic changes and fewer family members living close by to take care of their loved ones.
In the face of that, where people are opting for cash, paying them with their family, those people will almost, very large numbers will be women. So if you flip the lens and ask from a caregiver perspective, to what extent has this system, and the fact that people opt for cash, how does Germany fare when if you ask the question, how are caregivers treated by the system? So in North America, we have a growing literature and documentation that's really crappy. But does this actually address it in any significant way from a caregiver's perspective?
Well, this is a very good question. What they've been trying to do is increase benefits. So in addition to these cash payments that can be passed on to a caregiver, there are a number of other benefits that are allotted. For example, for caregivers who are not otherwise employed and working for more than 14 hours a week for a dependent, they'll have their accident and pension insurance contributions covered by the state. And yeah, which is really quite costly and generous. The other thing is they are given training courses in becoming a caregiver, but also when they choose to leave their caregiving responsibilities and enter the workforce again, they can, let's say if they were in the IT field, they can take part in training courses to get them back up to par. And then there are things like substitutive care, so that caregivers have 4 weeks off a year. And they're also given, there are grants for making home adaptations and making it easier, the job for a caregiver. So, yes?
Is there kind of a menu? So for example, suppose a given person can use meals, bathing, and meds. So the person could choose to have a nurse come and do the meds and a different person come and do the bathing, but get cash to pay for takeout pizza?
They can combine services, cash and in-kind benefits, but obviously that implies less of both, right? So I don't know exactly what formula they use for calculating what, but they have a good deal of choice in that, based on their care needs. I mean, they have to always be correspondent with how they've been categorized, what level of care they need.
Okay, and in the care dependency scale, is that a unidimensional scale? Or, for example, suppose there's one set of needs with respect to bathing and a different set of needs with respect to wound dressing. Would those be separately assessed?
Well, I can give you just a small, this is what, these are the various dimensions people are evaluated on. And it is, I have to say, one of the big critiques of the new system, because this has been elaborated in the most recent reforms, is that it's highly complex, and they had to do a great deal of last-minute revisions to make it less complex for the people who are carrying out the assessments and for people who have to understand the consequences of them. But essentially, there are 6 dimensions, activities of daily living being only one. And the reason for this has to do very much with the dementia population, because there you have the phenomena based on just activities of daily living that dependents in need would be able to, let's say, as a dementia patient, be able to brush their teeth and get themselves dressed and even cook for themselves. Nevertheless, their care needs were enormous because they couldn't be left in the house perhaps alone all day, or their sense of coherency was quite diminished. And so in order to take all this into account, people with reduced capacity, mental capacity, are better assessed with this new system. But it is extraordinarily complex with these 6 dimensions. And then they're weighted. So for example, mobility under Module 1 accounts for 10% of the final score, cognition and behavior 15%, etc.
And would those things be evaluated only by medical people, or would they, for example, be, social participation by somebody, a social worker?
As far as I know, they come with, in the case of the insurance fund beneficiaries, their representatives who come to carry out the evaluation come in a team of 2 or so people representing different levels of expertise. I believe also doctors' reports, the regular family doctor will also have a say in needs assessment. But I'd be lying if I said I knew more than that on how it's carried out. Any other questions so far? Okay, I'm just going to find where it was. Home care, right? So we also mentioned, very important, what provisions are set aside for caregivers, because that is in fact, if you recall, one of the main policy objectives that were set out by the system to take care of caregiver needs. If we take a closer look now at these cash benefits as in-kind benefits taking place in the home, I know the issue of vouchers is a catchword that's been used, it's certainly been used in my presentation title, and it bears saying that, seeing that this is a social insurance system, and I'm aware now that not everybody knows what that means, but basically you have a system in which the financing bodies, the insurance funds, are in direct communication with providers because they're contracting directly with them. And as a result, there's not a need for a physical voucher to be given to the beneficiary to pass on to a provider. Rather, payment is done directly between the insurance fund and the provider itself. Cash benefits rather go directly to the beneficiary. Okay, so that requires a bit, so there's not a physical voucher in this case. Is that correct?
Yeah.
And this is helpful because it reduces transaction costs, particularly for the beneficiary.
But if there's no voucher for the in-kind benefits, the person still has a choice amongst the different providers of the service, and presumably the insurer has a catalog of, here's my list of acceptable providers.
Exactly.
And you can pick from those. What if somebody wants to use a provider who's not on the list?
They don't exist really because they can't really survive, such providers.
So all providers are available, or do all insurers have the same list of providers?
Yes, regionally, obviously, what's in your region, what is possible. Of course, private patients would have, let's say, additional providers. But even the private market, providers can't really survive without also taking part in the social insurance system, because we're looking at a huge market. 90% of all beneficiaries are in social insurance. So,
do the private providers charge the same price to the insurance companies as they do to the privately insured individuals?
are they getting more money? Are they, in terms of
Well, in the US,
remuneration?
right, hospitals are notorious for, say there's a Medicare fee schedule, but if you walk in the door, especially if you come in the Cadillac, you're going to get charged a lot more.
Well, this is highly regulated, and the private insurance companies themselves can't charge more than the highest possible payment within the social insurance system. So there's a ceiling.
Mhm.
Yes?
Can you self-refer to home care, or do you need to get a doctor's referral? Like, how would you access
For inpatient care, you mean, or for services within your home?
for services within your home?
Okay. Here, basically, if the beneficiary goes to the doctor and says, you know, I feel like I need help, then they'll send somebody to the house. And you don't need a doctor's referral necessarily. I believe there's a number you can call and then say, well, you know, I think there's need here, and they'll send somebody. Of course, that needs could also be turned down if you perform too well, but. Yes?
So for the, you say at the top there, cash benefits assigned directly to the beneficiary to be spent on an informal caregiver.
Mhm.
So I can see why it wouldn't make sense for someone to use the cash because it's lower compared to in-kind, to hire a formal caregiver. But can people do that if they wanted to? Like, is there a restriction on that?
To use the cash benefits to hire a
Mhm.
professional provider.
Mm-hmm.
They wouldn't do it only because the benefits are significantly lower, and they wouldn't be able to afford it.
Right.
I'll show you in a bit what these benefits look like in terms of dollars and cents, and it's about half.
But is
value.
there a formal restriction on that? So let's say I can see a scenario where they maybe take a provider that wouldn't be covered under the in-kind, maybe it's a homeopathic provider or something.
Mhm.
Could they still do that if they wished?
Yes, they could do that, as long as they weren't officially a member of the service provider network within the social insurance, because they're not allowed to additionally contract for extra services. But they could, yes.
Okay.
Yes. Yes,
Are the providers public and private as well? Like, is it always
Absolutely.
split, all split?
yes.
Okay.
This was not always the case, but just to be clear, private providers are also servicing social insurance beneficiaries. So they're not just for those who are privately insured.
Okay, so who else are they for then?
They're also for social insurance.
Okay, so okay, fine, so.
Okay? Maybe we'll just to give you an idea what these benefits look like, and I'm terribly sorry for the German. We didn't get a chance to translate it, but if you just pay attention to what's in column 3 and column 4, and for example, if you look at the first row, columns 3 and 4, column 3 represents the current benefits for people receiving cash. And column 4 represents what will be the benefit in 2017 after an enormous expansion takes place. So at present, monthly benefits for cash benefits are €123 a month that they can pass on to an informal caregiver. This will jump to $316. That's at care level 0. Obviously, the benefits go up based on the care needs. So at the highest care level need, the cash benefits beneficiaries are getting €728. This will jump to €901 in 2017. Just to give you a feeling.
And what's the first column? The number of people eligible or something?
Yes, exactly right.
So Lorraine, I think it must be so, just on this question about whether the folks with cash benefits can buy homeopathy or whatever they wish. I would imagine there must be some regulation of what they're able to purchase, otherwise they could, you know,
Lottery
the
tickets.
son, the bachelor's son could be buying climbing ropes.
This does happen.
Yeah, I realise that it does happen, but surely it's regulated to try to prevent that, or is it just a free for all? You can just buy whatever you wish.
That's a good question. As far as I know, and I would have to double check on this, but as far as I know, there is really full discretion on how that money is used. If care needs aren't being met, there are, from the insurance funds, someone coming in every so often, every few months, to check on the beneficiary. And clearly, if they see that care needs are being neglected, then that's an alarm that goes off. But there have been reports of basically, nephews, nieces, daughters, sons using the money to buy cigarettes and not necessarily taking care of the care needs. But these are so far very few cases of that kind.
Right, but it just seems to me there must be regulation, otherwise they would, there'd be nothing to stop them buying cigarettes.
Actually, if you go to the fourth column, bottom row, after the expansion 2017, the maximum cap, am I reading this right? The maximum cash will be €900?
Yes.
Okay, that's $1,300 Canadian. So, but this would be money that I would give typically to a member of my family to provide care. Because in the market, $1,300 wouldn't buy that much.
That's right. And now, if you compare that with, Colleen, I'm going to double check on what the regulations are, because I'm not satisfied with the answer I gave you, but I will follow up.
That's great, because I
Okay.
think it's actually really important for other stuff we're going to do.
Okay,
Yeah.
I'm going to follow up. I made a note of it. If you
That's
compare
40
those
hours
cash
per year, a month,
benefits
30
to
bucks an hour.
in-kind benefits, again, column 3 represents what the current in-kind benefits are in euro monthly, and column 4 what they will be in 2017. At the lowest care level, we're presently talking about 231 euro, and that is for care level 0. So that's basically to have somebody check up on the dependent perhaps twice a week, make sure that they're taking baths and basic services. And at the other side of the spectrum of care, for the hardest cases, we're talking about 2,000 euro per month presently, and this will stay the same for the most extreme cases, because that's already reached a kind of maximum. But one step below that, care level 3, we're presently at 1,612 euro a month, and that's going to go up about 300 euro in 2017.
Are the cash benefits taxable income or non-taxable?
Not taxable. So in-kind benefits are significantly more generous, and that's obvious because it's more expensive to have a professional provider. Yes?
So level 3 would be institutional care, basically?
No, this is still for in-kind benefits within the home.
Okay.
And what we find is, in fact, at level 3, because the care level needs are so great, taking care of people at home doesn't save much money.
Is that 24/7, or how many hours a month is that, or per week?
That is just about 24/7, yeah. That's day and night care. Yes.
Just a question about benefits. So basically, if you're with the social long-term care insurance system, the level of benefits only depend on basically the need of care you have. Now, my understanding is that these benefits, basically, this is approximately only half of what is being spent in institutional care. And most people basically are being encouraged to get supplementary private coverage as well. So basically, what it means is that there's still a huge difference in terms of the care will be, well, not the level of care, but the quality of life level that everybody will get in long-term care residences, depending if you get supplementary private coverage or not.
Well, the supplementary private insurance that I mentioned earlier, there were subsidies created to to incentivize people to take up additional supplementary insurance. However, that was by and large, there was initial take-up with the first year it was introduced, but it represented a very small figure. I think of the subsidies created, only 10% were used. Germans, which is strange because Germans are very keen on insurances, they take up all kinds of insurance, and for whatever reason they were not willing to take this on, probably because they knew a huge reform was coming in the works that was going to expand benefits. So just long story short, this supplementary insurance plays a very small role in this. What you have, rather, is still a reliance on the social assistance scheme. So public money that people are dependent on, and out-of-pocket payments. And there are huge differences in I would assume the quality of life as a result of what you're able to pay for. And I will show you some figures on what people have to end up paying co-payments and whatnot. Yes?
I'm trying to do a little mental arithmetic on the 1995 euros per month.
Yes.
And that comes out to about $5 an hour at 24/7. Is that how much it costs the providers to produce that? Yeah, it's well below minimum wage, at least here. I assume it's higher in Germany.
That's a good question. Service providers are for in-kind benefits there are also some co-payments involved, and they are notoriously paid poorly. And this is one of the reasons why in the workforce there is great turnover and there's great recruitment and maintenance problems. But please don't quote me exactly on 24 hours of care. Maybe it's slightly less. But people are not earning, the providers are not earning huge money as a result of this. This level of care is very expensive to maintain within the home.
But you mentioned it in passing at one point, the system is designed at some point to create incentives to move from home care to institutional care. So you presumably create those incentives by specifying benefits.
Yes, I mean, the idea still is to keep people in the home as long as possible, but at this care level, it's too expensive, the needs are too great, and so people usually move into. I think this category of care is going to become more complicated as people are living longer with more chronic illnesses, morbidity that they're going to have. This is going to become a very, very, very problematic scenario.
Well, and I would assume that with a level 3 home care needs, you have a living care provider as well, so that the supplement is to provide like the supervision during the night when the primary caregiver is asleep, sort of thing. So it's I mean somebody that needed an outside person in the home 24/7 would probably need to be institutionalized, right?
Yeah.
So this is to supplement the 24/7 care for the care provider that already.
You mean the informal care provider that's
That's
probably
right.
there
Yes.
already, correct?
Right.
Correct. Yes and yes?
So then during that 4 weeks of respite, are they paying the person that comes in the $19.95?
Yes, they will pay the what is required at that care level to a provider, to a professional provider, to substitute the caregiver. Unless, of course, they can find another caregiver informal caregiver to take the place of the one who's on vacation. Yes?
This is kind of like steered to this, like, just how do people figure this out? Like, if it's so complicated and it keeps changing, like, how do people understand the services that are available and the options, the ways to navigate them?
It's a good question. I mean, particularly given the fact that most dependents are a bit older and quite sick, and so kind of has that information. And a lot of it is done the way it's done everywhere else, pamphlets for patients and so a representative of the hotlines from the insurance funds and things like that to try to make it as transparent as possible. But of course, it's quite complicated. Maybe we could just talk a moment about nursing home or institutional care. Here too, there are capped benefits, and there is no support for board or lodging. So this is really quite expensive and still entails a great deal of co-pays and out-of-pocket payments and social assistance. And here, beneficiaries too have full choice of provider.
For the co-pays, there's also a public pension system. Are the board and lodging costs in some way tailored to the level of benefits that are provided through the pensions?
I don't think that they're expressly tailored, no. I mean, standard of living costs and things like that take into account what a person's average income is through pension and old age, I assume, but not expressly tailored with that in mind. Perhaps if you take a look here at this table to give you an idea of what's left over at present, long-term care insurance benefits do not even cover the full cost of care for stationary inpatient care. Okay, so at care level 1, for example, total care would be something like if you look at column 1, 2, 3, 4, 5, column 5. At level 1, €2,393. And the benefits only cover nearly half of that. So we're talking about out-of-pocket care costs at about for €346, and then additional costs for board and lodging at about $1,370. So this is quite expensive. And here we see there is still a great deal of dependency on social assistance. However, it has been, dependence on social assistance has gone down dramatically with the introduction of the system, the long-term care system. Yes?
Sorry, so if a person is assessed at level 2, that person has the complete free choice to choose between whether they want home care or long-term care. And then from that, they can look at the different fee schedules at the level 2 to see what they would get based on which option they chose.
I mean, the patient or beneficiary has the choice, even at level 1, at a very early stage, to go
Right.
into institutional care. Most don't want that.
Because of the cost difference.
And also because of the quality of life. I mean, most people want to stay in their home as long as possible, especially if they're less dependent at that stage. But to flip it, people with extreme care needs can still choose to stay home if they wish. They can't be forced into institutionalization.
So if the care costs more than the amount provided by the insurance fund, how do the care providers survive financially?
Well, they depend on those co-pays and out-of-pocket payments and social assistance.
Okay.
Paid to the institution, presumably.
Yes.
Right, so the providers are employed or contracted with the institution. The patient won't be paying the providers directly inside an institution, I imagine, or would they?
Well, money is transferred between the patient, we're talking about inpatient care,
Yeah.
just to be clear,
In a nursing home?
in a nursing home. Well, his or her account would make a transfer, and obviously that would.
To the nursing home?
Yes.
Yeah, because somebody's got, the inpatient has to cover at level 1, 1,300 euros. So it's got to be a transfer from the patient.
Exactly.
Yeah.
So the provider's getting 2 streams of.
Which is exactly the same here
Yeah.
for
Well-
cost of living,
Hmm.
where you have to pay for the
And
board and
if,
lodging.
yeah, and if you run out of money to make the co-pays, what happens?
Well, presumably the social assistance scheme will take over.
And that's at the level of the municipality, not the lander or the federal?
The social assistance scheme is still at the level of the municipality, yes.
And is there any kind of fiscal federalism, we'd call it here, where the national government provides some funding to the municipalities to cover that cost?
There is not expressly for long-term care, but yes, there is fiscal federalism in general, where Lenda, like where I'm coming from, Bremen, is quite poor. So they are always getting money from the federal government transferred to them. But how they use that money it's like tax money then, and they can use it as they see fit, and it's not earmarked for long-term care per se. But the municipalities will be sure to fight for that money and for this, because long-term costs through social assistance is still a burden for the municipalities.
And if the municipalities are hemorrhaging money because they have to pay social assistance, what levers or tools do they have? Do they just have to pay it, or can they say we're...
They do have to pay it. However, they're hemorrhaging far less than they used to. And if you knew a bit about the political backstory to why this reform was possible, it was very much driven by the pressure from the municipalities to come up with a better solution to what was, as I mentioned, 80% of people were dependent on social assistance, who were in long-term care before 1994. So it is very much a success story of the municipalities, this long-term care insurance scheme, but clearly they're still burdened by it.
Is there any spillover from the pressure on long-term care costs to the pension system to say pension benefits, cash benefits, retirement income benefits are inadequate as a result?
This is because there were cuts made to pension, or because of
I don't know what the
long-term
history
care?
of the cuts in German pensions, state pensions were, but irrespectively, is this a source of pressure looking to
Yes.
the future?
There are trade-offs between, I don't know much about pension politics, I do know about health. And healthcare policy, for example, is very much a story about restructuring and reorganizing the system and cutting costs as much as possible. And many experts say this has very much to do with the long-term care insurance system being created.
Oh.
So there is a policy trade-off, definitely. Just be mindful of the time. I know because we've had it more as a dialogue, which I prefer. I would like to talk a bit about the financing of the system now, because I think this is a source of great interest and some curiosity, because it's a social insurance system. The social long-term care insurance system is a pay-go system, which means contributions are levied on income from wages and salaries up to a certain income cap, with parity of contributions between employers and employees, and since 2004, an extra contribution for the childless. I hate saying that out loud, but yes. Contribution rates are currently...
So which political party pushed that one?
I think that was the Christian Democrats.
Surprise, surprise.
Surprise, exactly.
It has some logic.
It does, it does.
Look, we do it in Quebec, so you know.
I mean, we're talking about a difference of 0.1%, right? Currently, it's at 2.2% for the people with children, and for those who do not have children, it's at 2.3. And this is set, defined by Parliament. Contributions are made by individuals in relation to income, not including assets, and not risks. And this is in contrast to the private system. For unemployed persons, the unemployment insurance will take on the costs of contributions. For the self-employed, freelancers, and pensioners, they have to pay the full contributions themselves.
So income in this case is more than income from paid work. It includes investment income, for example?
It doesn't include assets.
No, but the income on assets, interest, dividends?
Yes. Yes.
Okay, interesting.
So private compulsory insurance is a funded scheme which members build up provisions for old age during their healthy years. Here, premiums are calculated on the basis of risk. However, unlike in health, this is quite regulated. Risk rating is much less comprehensive. Gender can't be taken into account. Health status cannot be taken into consideration in calculating premiums. Pre-existing conditions may not be excluded from coverage. And as I mentioned earlier, the private long-term care insurance companies may not charge more than the maximum contribution rate within social insurance.
So how do they compete?
The private companies, here too, they compete at the level of providers, mainly, as opposed to insurance companies competing.
But if they all have the same providers?
No, that the providers compete with one another to get contracts with the insurance funds, whether private or social insurance. You understand? That's what I mean by competition.
I think his question is, what is the advantage to somebody of buying private health insurance rather than social health
Let me get it for
insurance?
this.
Why would I want that unless there is sort of a greater benefit?
Okay, that
So what is it, because the providers there are higher quality, or is it because the private health insurers have extracted some sort of better deal with them, or is there a movement of higher quality providers, or at least more of their time, to the private health insurance pool relatively?
now I got it.
Yeah.
Yes, there are some, let's say, fringe benefits of being in the private insurance scheme. For example, in health, you get to see the head surgeon or the top specialist in a hospital before you have to see anybody else. Whereas the social insurance patients would only see the top surgeon. I'm sorry, the translation's in my head from German to English, so I'm perfect right now. Would only see the chief of staff. If it was very necessary because of an expertise issue, whereas a private patient would automatically get that chief of staff to take a look at them. There are some different benefits in the way of a private patient or beneficiary getting to have a room on their own in the hospital and potentially in the nursing home. In some cases, shorter waiting times to see doctors. Although waiting times are not a huge problem.
But they're not paying doctors through this though, right? This isn't social, like this, the long-term care insurance.
No, I'm sorry, I'm talking about health and long-term care at the same time.
Okay.
In terms of long-term care, what is the benefit of being privately covered? There will be some additional add-ons and benefits, but the benefits package, the core benefits package is the same for those beneficiaries as it is for social insurance patients.
Okay, if I could piggyback on that and come back to the cream skimming question. If I want to be a private insurance provider, what do I do to attract people to give me their money compared to the private insurance provider down the street? I'm not allowed to take account of age. I'm not allowed to take account of well, maybe age, but sex or medical conditions. What the heck can I do in order to make more money than the guy down the street?
I'm assuming from this that the maximum rate of the social long-term care insurance is for the package of benefits that is covered by social health insurance. So the private health insurer will also be able to add accoutrements.
Exactly.
Right, so there'll be, the premium that they charge for the core services will be the same as the top social health insurance plan. But then in addition, they'll be able to charge a premium above that for add-ons.
Is that right? So they're not, basically not competing on the core?
Not on the core, no, they're not allowed to. But additional services, particularly, now fantasizing a bit, but in health, one of the big examples is acupuncture and things like that, where, they can offer additional services in that way. In long-term care insurance, private companies can...
German spas are.
Something like that, right, yes, German, basically.
So, but they're-
Thermal waters and stuff like that they love to.
I've heard this is true, but I've never had anyone verify this.
No, they still are. These are what? This
Right.
wellness.
Wellness packages.
Now, there's an urban legend or mythical tale about the travel insurance company that was located on the 5th floor of a building with no elevator. So, right, if you could walk up 5 stairs, you could get the insurance.
But
Right?
that's not the case here, right? You have to, at a certain income level, you can opt out. But it's highly regulated, right?
Exactly.
Okay.
Exactly. I mean, again, it comes back to there is some basic cream skimming
Just from wealth.
from wealth. So, moving forward, I think I covered this. So I think we should conclude by talking a bit about expansion, because it's really quite remarkable. Given this emphasis on cost control through the tight definition of need of long-term care, by as early as the early 2000s, the Ministry of Health was already aware of a problem in coverage, that it wasn't enough, and it particularly wasn't enough to take care of the needs of dementia sufferers, which was a growing and substantial portion of the elderly population. And this had to do with this measure of activities of daily living, which they ended up then substituting a more comprehensive measurement scale. And this took, so there was an understanding, we have to do something about this problem, we've got to expand. 2 processes were undertaken by the government, and one was commission-based and the other was legislative. To just very briefly go through the commission work, essentially the German government set up expert commissions, 3 rounds of them, that began in 2009. And each of these commissions drafted up very interesting policy recommendations, which in fact did end up into legislation. So I won't go through all the expert commissions and what they said and what they did. I would rather focus now, yes?
But it takes 3 rounds of commissions because the implementation cost is up. So yes, we know we need to move, but we're reluctant to move because of the costs associated. So it takes a while to push the system.
Yes, and in fact, the commissions, each of them had, particularly the last commission, which is now looking into the greatest changes and the greatest amount of expansion. There was a subcommittee created just to oversee the implementation process, with the full understanding that this is extremely complicated to realize. Yes.
But wouldn't it, if I think about the debate on pension reform here in Canada, the reason it takes 3 commissions or 3 decades is not because it takes more thinking, but because there's a pitched battle going on between the left and the right about how much redistribution to do, how big the state should be.
It's also the pay-go, right? I mean, if you have a pay-go system, then making any reforms to the current system requires some major sort of, increases in payment that start right away. And so that you need to transition those kinds of changes over a longer period. Otherwise, your premiums are going to rise from from today to tomorrow, just overnight. And so with a pay-go system, in order to assets to pay out, you need to have a lead-in period of paying in, right?
Well, if it's 100% pay-go, that's not a big deal. You just increase the premiums in 2016 and start paying out in 2017. But, which reminds me of another question. You know, our pension until recently, the retirement pension was essentially pay-go, but there was still a fund that was, 5 years of payout or 3 years of payout. Is there any kind of fund at all in the state LTC thing?
To support this expansion?
Not the expansion, but just since '94, since it was brought in.
I'm not quite sure. I'd have to double check that. I don't want to say something that's untrue. What came to mind in listening to your first question, though, if I just might add on to that, this issue of it being, because it's important to understand this expansion that is taking place and how it's been made possible. Because when I go through this now, I think you'll see it's quite remarkable, particularly the last years, how much more money is going to come into the system. It's coming into the system already in 2017. And this has to do with the fact that there was, despite what took 3 decades and a great deal of political battling between the parties and within the parties about how the system should look, by 1994, everybody was on board. All the major stakeholders, all the corporate actors, all the parties, everyone was signing on to this thing. So everybody's political legacy is tied into its success. And as a result, there's been a great enthusiasm even about, it's become kind of the policy darling of the welfare state, and this is true amongst all parties, basically. And so you don't have this problem necessarily. There's really, it's really quite an unusual political animal in that sense, this policy area.
So when you talk about this major expansion, are you talking about a 10% or a 100% expansion?
And we talk about that now because I can show you more concrete numbers. If you don't mind, I'm going to jump to the more recent because of time. We only have 20 minutes to 1. You guys might still want to eat. Take a look at, important to note, in 2008, something called Care Level 0 was created. And this is important because it captured a level of need for people who were not falling into the care levels 1 through 3, i.e. dementia sufferers. And also, it was the first time that, based on this level, in 2013, people for the first time within Care Level 0 received also cash and in-kind benefits. Prior to that, they were only given a small amount, an annual sum of €460 a year to support their needs. So 2013 was rather the big bang and boom in expansion. And it also, the reform, this Pflegeneuausrichtungsgesetz, also introduced significant increases in benefits of care levels 1 and 2 across the board. 2015 is quite remarkable because here we have a new definition of need of care that was introduced, and with it entitlement eligibility, which will take effect now on January 1st. And here, I would like to show you what this means in dollars and cents or euro. For example, and I apologize if this is in German, Pflegesachleistung refers to in-kind benefits. And the numbers you see for each of these care levels, 0, 1, and 2, are the increases in euro, not the total amount. So we're seeing per month €225 more for people receiving in-kind benefits within care level 0. 215 more for care level 1, etc. What we're looking at for 2017, is an influx of €4.18 billion into the system. And that number is expected by most estimates to be matched in 2018, 19, and 20 at least. And this represents €5 billion in increases in services, cash, in-kind, and stationary care. And then a whole series of categories that follow that include the pension contributions for these informal caregivers, etc. But we're looking at an enormously generous reform.
But $5 billion on top of what was being spent before 2016.
Exactly. This is an increase.
No, but what was the base then, before the increase?
I'm sorry, I did not show you this figure yet. This follows, and again, I terribly apologize for the German here, the annual spending. And if you look at the last row, 2005 to 2013, I have numbers for here, and an estimated figure for 2014, sorry. We were looking at, in 2005, we were spending 0.02 billion per year for the system, to keep it afloat, social insurance system. And ending in 2013 at 0.44 billion. So that's a lot of money already. And now,
This is only social insurance for long-term care.
yes, social, yes.
No, but that's like a tenfold increase from
Yes.
440 million to 5 billion. That's huge.
It's huge, it's huge. It is, this is what I meant by remarkable. I mean, it's really quite remarkable, and if you see this in comparison to developments in other areas of the welfare state, there are certainly trade-offs to be felt.
So these are all in billions, they're not percents or anything like that.
It's €1 billion.
And what's the line that says Einnahme ingesamt? Fourth line?
That's total, total income in terms of, what are we looking at? Which one?
Third line down.
Einnahmen insgesamt. That's the calculation of, through contributions and what they call sonstige Einnahmen. Sonstige, other forms of income, that would be in the form of supplementary insurances and things like that, I believe, are calculated.
So is this income to the insurance fund, or is this
Yes.
income of individuals?
To the insurance fund,
The long-term care insurance fund? Or-
yes.
Oh, but then that's not as big an increase, because if you're adding 5 billion to 25 billion, that's 20% increase. If you're adding 5 billion to half a billion, that's a tenfold increase. So the bottom line is 0.44, 0.48.
Okay, yeah.
But
So-
Still, I would argue that's a huge increase.
The line in bold,
Oh, sorry.
ending in 2013 at 24.69 billion, represents what? 24.69 is?
That is the amount of money coming in through contributions and whatever additional sources, like this supplementary insurance and stuff like that.
And the 2317 is what was paid out? The
Yes.
outstanding?
Exactly.
So that the actual expenditure for long-term care in 2013 was 23 billion.
Exactly.
Okay.
So,
So the additional 5 billion then is a 20% increase, approximately.
yeah,
Okay.
which I would still in welfare state terms say is a huge amount of money.
Yeah.
You're less convinced though.
Oh, no, it's a big number, but it's not as big as a tenfold increase. You know,
Yes.
This question may
And-
be premature, but is it because in Germany, politicians have figured out that large numbers of voters have friends or family who need care, and this is a potentially winning investment, simply because of the ubiquitousness of the channel?
I think this is definitely part of the story because all of these major expansion reforms took place prior to elections. So this is certainly part of it. The constituency is getting older. Their parents are getting older. This is something that all voters are interested in. Absolutely.
Well, and the dependency ratio in Germany is like, it's remarkable, right? It's in terms of the elderly, it's like growing faster than any other country in the world. And so, I don't, you're looking at like a speeding train going to a wall if they don't do something.
Exactly.
except I thought that it's what, closer to 20%, where Canada it's 13 or 14%, the 65 plus population.
I think it's
But-
30%.
I believe it's closer to 30 as well.
Well, but I
So,
thought it was fairly stable. You know, Japan's got a rapidly growing one, but I didn't think
That's true.
Germany's was growing as fast. All right, but anyway, just to put things in context, now that we're in Canada, is the last budget increased the child benefit system, and I think there might have been $1 billion put into it. So, you know, that's on the same scale. And the minister responsible is certainly celebrating it as a huge advance, but I don't think in public policy terms it's anywhere near that on the Richter scale, at least for public policy commentators here in the country.
Okay. Because it's still not enough to meet the needs, or?
No, adding $1 billion, that's what happens after elections.
Okay.
But after the Harper years.
After Harper, yes.
So maybe I might jump in, please, because we're only 10 minutes from the end. I did want to say a couple of things about the relevance of this to the Canadian system. So Lorraine and I and Michael Wilson are investigators together on a new CIHR grant that is looking at issues around financing long-term care. And what we are doing is attempting to understand the possibility of different models around the world, particularly the German model and the Dutch model, which have these big reforms that have happened to meet or to provide universal long-term care insurance plans, arguably much more generous than what we presently have across Canada. So across Canada, as is usual, because of the federal, provincial, or the provincial jurisdiction over healthcare, each province has its own very different approach to long-term care. In Ontario, we have a universal plan in the sense that everybody is covered, but what we find is that it's not particularly generous, and so there are significant wait times for people to be able to access publicly funded nursing homes. So the result is that many people are waiting from the point of assessment when you're already extremely frail, many, many years before they are able to access a nursing home in some situations, requiring them to fall back onto their family, friends, and personal resources, or to be institutionalized more frequently in a retirement home, for which they receive no public funding, which are private for-profit organizations. And generally they're paying completely out of pocket for this kind of care. Only about 1% of Canadians have private health insurance for long-term care. So there isn't any kind of robust market in terms of provision of long-term care insurance from private health insurers, as you're seeing in Germany, and I'm assuming that has only come to pass because of basically a government mandate and regulation requiring them to provide that insurance to people who ask for it. So no appetite for Canadians to buy private health insurance. I suspect what's really happening is that most people actually have no idea about the deficit in financing of long-term care insurance, unless and until they're trying to get a parent into the system, and then they find out the hard way that our so-called public plan is basically non-existent. The governments that we're working with on this project, we have kind of a partnered grant with Health Canada, the Ontario government, Quebec, Nova Scotia, and Alberta. We're really thrilled to be working with policymakers in all of these provinces. And they are interested in figuring out creative ways to put more dollars in the system, but unsurprisingly, they're not particularly interested in calls for more tax dollars in the system, given that many provinces are paying 50% or more of total government spending on healthcare. They really just have very little room to maneuver. So unless and until the feds come to their aid, and we have calls, for example, for national pharmacare, national home care, there's just no way the provinces are going to be able to fund these things on their own steam. Unless there is the possibility that we're interested in of expansion of finance through something like social health insurance. So a kind of CPP model. So rather than coming directly out of the tax fisc, we're wondering if there might not be more political appetite for something like a CPP payment that we would all contribute to be able to purchase, to ensure that we have long-term care insurance in the future. Really, we should have started this 20 years ago, but we haven't. So that's the kind of thing that we're interested in. Our provincial partners are also quite interested in this idea of what I call the voucher which is basically that instead of being institutionalized, that you can take a cash sum and spend it in your home or in your community in the ways that you think is appropriate. It has a lot of appeal because of maximizing autonomy, flexibility, choice. Concerns, though, that we want to research are, what is the impact on women's participation in employment? What do we have concerns around quality and safety of the care that's actually delivered potentially by family members? The kind of training, etc. Can you attend to all of these things through regulation? The fiscal concerns, the financial concerns about the nephew running off with the dollars, these kinds of things, or the niece, we should be not so genderfied here. So I think those are really interesting things that we want to explore. We're doing 2 case studies. Germany, Lorraine's the head of our German case study, and then we're also doing a case study of the Netherlands. And interestingly, the Netherlands spend significantly more than Germany through their public plan, although perhaps Germany's starting to catch up now. So we want to try to understand why, because they obviously have fairly similar kind of population and fairly similar aging, as I understand it. So what is it in their plans? We think it's probably around women's participation in the workforce, but we don't know. So we want to try to understand that. Why is there that difference? And how would that, if we're thinking about designing something similar here in Canada in a particular province, which model would we go for and what are the costs and benefits and trade-offs to look at in terms of those sorts of things. So that's where we are at. We've just got funded, we're just getting going. This is the first time I've met Lorraine in person. And we're actually going to meet with Health Canada tomorrow to talk about some of these things in a more in-camera session and see what they think. So I'll end there and hand it back to Patrick for last
Okay, so we have a
minutes.
few more minutes. So for those of you who have not yet had an opportunity, if you have a question, this is your opportunity. Great.
So I was curious, you mentioned it's a pretty strict definition for eligibility. Do you have an estimate of what proportion of people who are receiving or needing long-term care, home care, are actually getting insurance benefits? So, because for example, is it just a very small tranche of people at the top, and then there's all these other people paying out of pocket still because they don't meet the eligibility criteria?
I don't believe there is data on people who who have needs that aren't being met because they're not being qualified into the system. Now that entitlement levels of care have been expanded to include 0 as well, and this is really something that's not talked about, interestingly.
Because that's certainly an issue, like say here in Ontario with the CCACs, and there's lots of people who would like home care, but aren't getting assessed as meeting the criteria or deserving of it. So you can have insurance, but if you can't collect benefits, it
There's also some research that it's just not a calculation of clinical or social need. There's also kind of an implicit calculation of, do you have someone at home that could do this for free? So any willing victim lying around, and that informs the assessment process as well. So there's some concern around that here too. So it'd be interesting to see if anything similar.
But just on that point, does this system address that policy problem we have at least in Ontario, and I suspect other provinces? Because we have this sharp distinction between paid for home care or long-term care and unpaid informal caregiving, there's this huge divide. Whereas if you allow for payments to caregivers, presumably that it's more smooth transition.
Yeah.
Is that fair?
Well, in terms of what we do see in Germany is that the cash benefits that have been set up for informal caregivers have in fact incentivized and stabilized caregiving in this form. This is still the first choice of beneficiaries, which of course does keep costs lower than perhaps a system like what you see in the Netherlands, where there is less this dependency, as far as I know, on the female caregiver part.
Any other questions? If not, I know people have to go to other appointments.
Yeah.
I want, on your behalf, to thank Lorraine and Colleen for a very useful presentation. And this debate is just getting going in Canada, so this will help us all. And so this is excellent, so thank you very much.
Yeah, thanks.